All right. We are live. It is August 8th, 2025. It's actually my 16th anniversary today. My wife doesn't watch the show. She's not a fan. No, just kidding. But I'm David Dayen, Executive Editor of the American Prospect. This is the Prospect Weekly Roundup. We do this every week at 12:30 Eastern. And with us today, it's my pleasure to bring on Suzanne Gordon, who is a veterans healthcare reporter and researcher, and also runs the Veterans Healthcare Policy Institute. And Suzanne, thank you for being here today.
Thank you, David, for having me. I'm actually co-founder.
Co-founder.
So I run it with a few people, but
there you go.
Fair enough. Might say I try to run it by myself, but anyway.
Fair enough. Well, we brought you on because we want to talk about this terrific investigation that you did for us at the American Prospect. We actually run a lot of your stuff. You can find it all at prospect.org/veterans. But this piece was in our latest print issue. And, it's about veterans healthcare, but it's really about the state of healthcare in America more broadly. So tell us about, what you wanted to look at with this investigation.
Thank you. And David, I just think you're so right because, we tend to view veterans healthcare as somehow out there, like
right.
apart from the regular healthcare landscape. And the Veterans Health Administration, which is the largest healthcare system in the United States, people just somehow think it's like not there. It's like invisible.
Right.
And you can't look at veterans healthcare without looking at the rest of healthcare in America. And that's kind of what I did is they've been trying to privatize the Veterans Health Administration, which is the biggest sub-agency in the Department of Veterans Affairs, and they've been trying.
And how many people get their health care from the VHA?
About 9 million.
Mm-hmm.
And not every veteran is eligible for VA care because you have to have the right discharge status. If you have a dishonorable discharge or what they call an other honorable discharge, you can't get benefits. You have to have a proven service-connected disability and or a low income and or been in a combat zone, blah, blah, blah. And so it's 9 million people, probably more eligible, but they don't all apply.
So 9 million people. And as you've been reporting for a long time now, there has been this move toward privatization. It's a bipartisan move as well. So, what are the steps that have been taken to move these 9 million veterans, or at least a significant subsection of them, into the private sector?
And it's not just 9 million veterans, it's over $130 billion. That they don't really care about bodies, they care about the dollar signs.
Right.
Well, there's been many moves which we've reported consistently for the past 10 years. I mean, it started with the choice program, which allowed vets to go to private sector providers if they met certain criteria. They were limited criteria, and it was supposed to be a temporary program for only 3 years, like a kind of a very large national pilot, if you will. And then, Trump and the Republicans who had McCain had promised Bernie Sanders it would be temporary. And then he said, oh, I was crossing my fingers behind my back when I made the promise. And then it turned into the the VA Mission Act. And that was supposed to be,
And that was like Trump's first term, right? 2018.
That was in Trump's first term, and it was his biggest legislative win. Thank you, Democrats, who voted for it, and the veteran service organizations who lobbied for it. And that was supposed to be less limited, but still limited. And then, of course, Trump and his VA Secretary, Robert Wilkie, made criteria for accessing private sector care very broad. And then now we see, and so there was this very coy, and we wrote, I think, the best piece ever on this issue in the Prospect called Fact Checking Fact Checkers, where, the people in Washington say, oh, this isn't privatization. Sending, 9 million people or 6 million or however many, 60% of 9 million to private sector providers, that's not privatization because the VA is still there, the bricks and mortar.
Right.
And all that. And they won't use the word privatization, they use the word choice, which is why our article is titled The Illusion of Choice. And
Right.
so they consistently are trying to expand the program. There's a bunch of pieces of legislation in Congress now that are very dangerous. The Access Act, the Freedom
And
Act.
they call it the Veterans Community Care Program, right?
Right.
That's what
So
when you see community care, what that means is privatization.
right. And I hate the word community because it suggests that, the VA
Oh,
is
yeah.
somehow part of the community, right?
Right. Well, it's
the
Orwellian
largest-
too, because when you hear community care, it sounds, I like community care. That sounds really good. But what it means is taking people out of the VA health system and moving them into the private sector. That's what that means.
Right. I mean, community is cozy, comfy,
Yeah, exactly.
communal, communist.
Right.
And this is sending people to private equity, hospitals with
To
private
big
equity.
hospital networks, private equity companies, et cetera. So, so there's been this move over many years to privatize the VA system. And, one thing that you bring out in the article is how unique the VA health system is in terms of how it responds to the very particular needs of veterans.
Right.
That it's unique in that sense. There's an integrated care system, and things are done in the VA system that it's hard for the private sector to replicate, right?
Absolutely. And you began this conversation talking about the broader healthcare system.
Well, we'll get there. Yeah.
And in the VA, they do things that they can't do in the broader system because they're all on salary. There's no incentive for Dr. Smith to, give you more stuff or less stuff. It doesn't benefit him either way or her. And, they also deal with a very specific patient population that has, probably 41% or more have mental health problems. They have substance abuse problems. They're at higher risk for suicide. They have more chronic pain. And they have a lot of socioeconomic problems. I mean, the VA is actually a healthcare system, and healthcare is way more than medicine, although most people don't know that. And we have a broken episodic medical treatment system. And the article really focuses in on how broken it is. But these patients are very different. They have very specific problems. And Doug Collins, who's the former Georgia congressman, who's now the Secretary of Department of Veterans Affairs, who knows zero about healthcare, he thinks a doctor's a doctor's doctor, a patient's a patient's patient. You got a hospital here, you got a hospital there, send them wherever. What's the difference? And that's
exactly. It's not the case. So you have this very particular population. There's a drive to move them into the private system. And then at the same time, as we've been writing about a lot, the private sector healthcare system is about to be devastated by these massive cuts from the One Big Beautiful Bill Act, including over $1 trillion in cuts to Medicaid, potential $500 billion in cuts to Medicare, the expected rise in premiums that's going to lead to an increase in the uninsured population because they're taking away premium supports from the Affordable Care Act. So the private sector, if you look like in the future, you have more veterans coming into the system and a system that's going to be weakened with probably lower staffing levels and things like that. But what you did, which I think is really fascinating is you said, okay, let's set a baseline. What does the private sector system look like right now before all of these things are going to happen, before more veterans are pushed in and before more money is taken out? So it was that really the impetus? Like, I want to see whether this system can
Yeah.
handle what is going to occur in the future.
Yeah, so the real impetus of this is yes, I mean, I've been writing about the broken American healthcare system for decades. And I'm, a big advocate of a national health system. But the big impetus for this was a phone call from a radio station in St. Louis that
Okay.
said, would you be on? And what we want to talk to you about is, how come we just can't give these veterans a voucher and send them to the hospital across the street and the doctor across the street? And so, in preparation for my, conversation with this guy in AM radio, I just started Googling around stats, about healthcare in Missouri. And it took me about an hour, to assemble like shortages of primary care providers, mental health providers, the hospital across the street. Did you know? I guess he didn't, had just closed, 2 months before. And so I kind of barraged this guy with these statistics, and he kind of collapsed, And oh my goodness. And so I thought, this has to be done on a state level for every state. And so
Right.
basically, this is not my fort, going around collecting data. I mean, this is, and so I decided I needed to assemble a picture of every state. We had done this at Veterans Healthcare Policy Institute when we did a report on the crisis of rural healthcare. And we looked at Montana and Kansas, where at that time, the chairman of the Senate Veterans Affairs Committee, who was a big privatizer, John Tester, although a Democrat, and Jerry Moran, who was ranking member from Kansas. So we had done a quick look
Hmm.
at Kansas and Montana, but I decided I want to look at every bloody state, which I did. And guess what, David? They are bloody. Some are bloodier than others. If you are bleeding out, do not, you're kind of out of luck if you have mental illness. And so that's what I did is I looked at every state and spent months and months and months just kind of collecting this data, which is all out there. It's not my data. I didn't make it up. Who could make this up?
Yeah, absolutely. So, oops, sorry. Yeah, tell me where this data came from. Like, what sources did you
Oh boy.
consult in trying to build this architecture of what healthcare looks like in America today?
Well, there's reports. One of the best sources of information, and I would recommend it to anybody anywhere, is what it's called the Healthcare Information Hub. And they have these amazing charts and maps that are really
Hmm.
quite vivid of what are called healthcare professional shortage areas. And that data is collected by the feds. So I consulted them. There's a group called CHQPR, the Center for Healthcare Quality and Payment Reform,
Right.
Chartis. There's a company called AMN that looks at wait times. There's the VA data. I mean, one of the things that really scared me the most, given what's going on in DC now, is there's all this VA data about, what's the income of veterans, how many veterans receive compensation, et cetera, for every state. And I was really scared that they would take this data down, because you
Hmm.
find websites now that are gone, right? And so you can get this data and then there's just various reports. The Kaiser Family Foundation, which is now called KFF, does a report on mental health care in each state. The Robert Graham Center and the Cicero Institute do physician shortages. And so I just spent my time, going through the same data for every state. And then, various states have better or worse state government or
Right.
state of the University of Reno, the University of this, of Tennessee
Right.
have. And so there's just out, I mean, literally, I could have written, 50 pages on every state. And
Right.
I wrote three because I don't know how many I wrote.
Right. So, so you consulted all of this data. Some of it's government data, some of it's private data, and tell me some of the top lines. Like, what did you find in terms of where we're at with healthcare?
Well, I mean, I have known for a long time, it's hardly a newsflash, that the American healthcare system is broken, and I knew a lot of the national statistics. But when you go into each state and you see how terrible it is, and even states that are better, like Vermont and California and so forth, um, California is a great example. I mean, there's sort of quote unquote pockets of plenty, and then just these deserts, Northern
Right.
California. Some states, I mean, the Rural Health Information Hub, and I really want to give them a plug because they were very kind to let me reproduce their maps in this report. But they're
Well, we
very
should say the report is up. Tell people where to find this report if they want all
well.
the
It's
information.
going to be when in a little minute, maybe hours. It's going to be on the Veterans Healthcare Policy Institute website, and that's
Okay.
you
And
know
that's where at veteranspolicy.org, correct?
Yes,
Okay.
veteranspolicy.org. We
Right.
have, I'm finishing the final corrections
Right.
and
And you drew from that report to create the piece that we have
yes.
in the
And
prospect. Okay.
and yes, and um as well as creating I mean, one of the things that we did in the article was to give you a veteran, an anonymous veteran who's a typical veteran patient
Right.
who was described to me by an amazing primary care physician at the VA who shall remain nameless because if you say anything good about the VA in this administration, you could be fired,
Right.
which is pretty interesting. And it shows, I think, the complexity of these patients that, I mean, it's not a fiction. These patients have, 16 different problems.
Yeah.
They're on 20 different meds. They're being taken care of by a platoon of,
Right.
doctors and nurses. And guess what? They all talk to each other as opposed to the experience that most people who are outside the VA have, which is, I mean, my doctors don't talk to each other. I'm the
Yeah.
communicator.
So let's just go through some of these numbers because they really are staggering when you put it all together. So you write that, and this is from The Illusion of Choice, the article in the
Right.
prospect, more than 89% of counties in America are officially designated by the federal government as primary care health professional shortage areas.
Right.
And those 89% of counties contain 80 million Americans,
Right.
which live in areas without enough primary care providers. And almost all of America's rural counties are at significant risk in this. And you pay attention to rural counties because about a quarter of American veterans live in rural counties.
And a lot of
Um,
Americans, I mean, live in rural
well, a
counties.
lot of Americans, period, but a quarter of all veterans, which is
Right.
a high number.
Right. Right. Absolutely. And then there's one of the other things that was really striking to me, which is in the article, when I went through the state by state data that the VA compiles, is how poor veterans are. I mean, that was really striking to me
Right.
because I included income data. And I mean, it varies according to the state, but the way they do it is they look at the percentage of vets that have a personal annual income of 25,000 or less, and the amount of vets who have a personal annual income of between 25 and 50,000.
Mm-hmm.
And it's really a staggering number. I mean, it's about, more than 25% of in each category. So that means that 50% are between, I don't know, 45 and 50% of veterans earn less than $50,000 a year compared to 12% of Americans. They also show how many veterans earn more than $200,000 a year. And, something like 12% of Americans do, and between 2 and 6% of veterans. And this confirms what the other data shows, that veterans are poorer
Right.
than most people. So, they can't make up, like if they can't, get care at the VA, I mean, they can't like reach into their pockets and pull out a lot
Right.
of
And
cash.
I think we know, that there's this relationship between health and wealth. You look at it in mortality statistics, and wealthier people live longer. And that's because in America, Republicans often say that we have the greatest healthcare country in the healthcare in the world. And that's true if you can afford it, but only if you can afford it.
Well,
And
but actually, I would actually disagree with that. I
okay.
think that if you can afford it, you can get really good medical treatment, but it's often uncoordinated and fragmented.
Well, that's of course true. Yeah.
And you can't get, I mean, literally, the VA gives concierge care to poor people. Even when the concierge care, that they have in America, if you the high end stuff where it's 22 grand just to like walk in the door,
Right.
they don't have a pharmacist on staff. They don't have a social worker. I mean,
Right.
I'm working on a book about something, and I did some secret shopping at a concierge practice near
Hmm.
Palo Alto. And basically I said, "Oh, do you have a social worker?" And they were like, "A social worker? Why would we have a social worker? Do you have a pharmacist?" "Well, you can go to CVS." I mean, they can't even
Right.
imagine, that like,
And one of the reasons for that is because of these shortages that you described. And so we've already talked about at the, sort of the macro level, 89% of counties with that are professional shortage areas. But let's, you go into the state by state numbers and it gets even worse. So I'm reading again from your report. Arizona will have a shortage of 8,280 physicians within the next 5 years. Texas will have a shortage of 20,420 physicians. Many of Louisiana's parishes, which are counties, and other states call them counties, Louisiana calls them parishes. Many of the parishes have one or two full-time primary care physicians.
right, right.
And nearly half of Kentucky's primary care physicians only work in two counties. Kentucky has 120 counties.
Well,
Uh, it goes on and on. States like Montana, Idaho, South Dakota, Wyoming, severe shortages of mental health providers, of primary care providers. In parts of Colorado, east of Denver, there's one primary care physician for every 5,600 residents, which is just way too much for any primary care physician to see all these patients.
well, and
It's
also
crazy.
And also, even in places that seem to be well stocked with primary care, docs and so forth. I mean, like, I live in San Francisco. I mean, when my primary care doctor quit practice, it was insane. I mean, I
Mhm.
know doctors who work at UCSF who cannot get a primary care doctor at UCSF.
Right.
And if you look at one of the aging of the physician workforce, the same is true with mental health care. I mean, mental health
Right.
care is even worse. It's like, I think it's like,
Yeah.
123 million people live in healthcare professional shortage areas for mental health. But even those of us who live in so-called well-stocked urban areas, a third of psychologists don't take health insurance of any kind. 45% of
Mhm.
psychiatrists don't take health
Mhm.
insurance of any kind. So yes, it's groovy if you live in San Francisco and you need cognitive
Literally.
behavioral. Yeah, right. And you need cognitive behavioral therapy. If
Right.
you can't, pull out $325 a session in San Francisco, I mean, you're out of luck.
Yeah. So this manifests itself, as you say, in people just not being able to acquire a primary care doctor, a mental health professional, et cetera. But it also, even if you are able to find one of those doctors who can help you, it manifests itself in terms of wait times. So you had some stuff about wait times in the article. Tell me about that.
So basically, it's pretty interesting, that there's all this, hubbub about people in the VA have to wait too long, 20
Right. I mean,
days.
that was how they sold privatizations.
Right,
There's all these wait times in the VA, and so we have to get them out to the private system.
So the only system actually in America that uses wait times as a publicly known, I mean, a lot of systems calculate their wait times, but they won't, and they know what they are, but they won't tell you. But the VA actually will tell you. And so there is a company called AMN, which used to be called Merritt Hawkins, and they occasionally, sporadically do these surveys. Sometimes they're every 2 years, sometimes they're longer. And they calculate wait times, but only for 15 metropolitan areas and in 5 specialties. And it's really staggering. I mean, you could wait in America as long as, I think the wait time for the longest wait for dermatology is 291 days. I mean, that's like almost a year. You could wait 231 days for an OBGYN for a woman appointment. It depends on the place, but I mean, I know anecdotally, and I think we all know anecdotally, I know someone in California who had a serious lung issue, had to wait 5 months for a pulmonologist, and then 2 weeks before the appointment was told that the pulmonologist had left, and he had to wait another 4 months, 9 months. So what does that mean? It means you go to the ER. I mean, if you can't get in the VA, the wait time might be for 30 days, maybe.
Right.
But and I mean, urology is very interesting because for men who over in their 60s, often suffer from enlarged prostates, right? Urologists don't like to treat BPH, benign prostatic hypertrophy, because it's not lucrative. And so they save their appointments for prostatectomies, for surgery or something like that. And so you could wait 5 months for an appointment, because
Right.
not because they're not available, because they prioritize what makes more money. So even in places that are well stocked with physicians, you really have to look more granularly at the data. You can't just look at a list of how many licensed physicians there are in New York City. Do they take Medicare? And the other thing that's really interesting about, I mean, so essentially what I tried to do, they're telling veterans, Doug Collins, Marsha Blackburn in Tennessee is one of my favorite spots, Louisiana, Arkansas. These people are on the Senate Veterans Affairs Committee. They live in these states. They should
Right.
know.
Right.
These are part of the terrible 10, of the 10 worst states for healthcare. And they're the biggest promoters of, sending vets into the private sector. These veterans in the VA, I mean, maybe they, don't like this or they don't like that, but they have been sheltered from the failures of the American healthcare system. And
Right.
these senators and Congress people, Kiggins in Virginia, who's a nurse practitioner, whatever. And they want to send veterans, they want to take a healthcare system for really vulnerable patients and destroy it and send people into what has been terrible. I mean, the terrible 10, moniker is way before the big, beautiful bill. I mean, after.
Right. And what I think is interesting is that this ends up hurting everyone, right? So veterans are harmed by moving into a system that doesn't really focus on their specific care needs. And then they have maybe longer wait times and harder to get actual medical treatment. But all of us who are already in that system are also harmed by basically competition from millions more patients for
Absolutely.
a narrowing series of doctors.
Oh, yeah.
And And I want to get to what you mentioned. You hinted at it before, the aging of the healthcare workforce.
Yeah.
This is a serious problem, and it's compounded by the fact that one of the major training grounds for medical professionals coming up through the system is the VA. So, talk about the aging of the healthcare workforce and how this is made worse by what's happening at the VA.
Well, I think that you have an aging healthcare workforce. The statistic is not at my fingertips. And,
I got it in the story. Physicians over the age of 65 make up 20% of the clinical physician workforce.
right.
And another 22% are between 55 and 64. So in 20 years, almost half of those of the total physicians are likely to retire.
Well, and then something I don't think I put in the story, but I put in the big report is there's this phenomenon of physician burnout. So you're seeing,
Sure.
people who are in their 50s or sometimes even less, who would have been working, or people who are like 60 who might have been working
Right.
till they're 70, leaving practice because they're burnt out. And burnout is like not a good thing because
Right. And some of
they're
that is because of who runs these
right,
agencies and what they run it for the benefit of. Like private equity in
right.
healthcare has caused, I've heard healthcare professionals describe it as moral injury.
Oh yeah.
That this moral injury where they want to care for their patients, but they literally can't because of the pressures, the profit pressures placed on them by private equity. That's accelerating a lot of this burnout.
Yeah, and I mean, you look at what private equity has done, like in Massachusetts and in Pennsylvania, where, this private equity firm bought Hahnemann
Yeah.
Hospital, I think, and then, just milked it and closed it. In Massachusetts, Steward Healthcare,
Steward,
is,
yeah. We've written a lot about Steward,
owned
a
by
lot about Steward in the
Cerebrus,
Dayen. Yeah.
private
Hmm.
equity. They closed a bunch of they sold a bunch of hospitals. I think it was 8, and closed 2. Um, I mean, and more. I mean, there's been wonderful reports by Richard Scheffler from the University of Berkeley, at Cal Berkeley School of Public Health, who's looked at the devastation of private equity. They own more nursing homes. They own, the other thing that,
But
I
yeah, go
go ahead.
ahead.
No, I mean, I think that, you can't just you have to look at the experience of these doctors. And one of the nice things about this is that doctors are unionizing. I mean, the primary care docs at
Hmm.
Mass General just unionized. And, I think
This is
because
true across the country. We've written about that in the past couple of years. But talk about this point that how the VA plays this pivotal role in training healthcare professionals.
yeah, that's a really big issue. Um, so basically, the VA runs is the hub of the American healthcare professional teaching system.
Hmm.
And VA trains 40% of, I mean, 40 different healthcare professionals and 70% of American doctors,
Mm.
largest trainer of nurses, largest trainer of psychologists. So we have a nursing shortage, primary care provider shortage, mental health professional shortage, catastrophic in every way. And the VA is pivotal here. And they fund, for example, residency training slots, right?
Right.
And
So if you're a young, someone in medical school and your residency, which is a critical portion of your professional development, there's something like 75,000 slots at the VA that these residents go to.
Now, they may not end up working at the VA, although some of them will, and some of them certainly will be, and they will all be trained to a certain extent, depending on how long they're there, in veteran-specific problems, and to recognize that veterans even have specific problems. But if they train, doctors, nurses, psychologists, OTs, PTs, whatever. And in order to train them, you have to have the funding, but more importantly, you have to have the staffing because somebody has to supervise the trainee. you know, you have to stop them from killing patients,
Right.
teach them how to absorb and integrate, their lessons. So you have to have staff. So, one of the things that Collins, the head of the VA, Mr. Know Nothing About Healthcare, doesn't understand is, he wants these doctors and psychologists to see more patients and be more quote unquote productive. But he doesn't understand that some of their productivity, and this is really productivity, is producing future generations of
Right.
themselves, reproducing themselves. So
Right.
they have to have time to teach, right? They have time to like read up and know what the latest research is. Oh, no, all of that is like non-productive, right? You're not
Right.
contributing to American prosperity. They have sent letters when they tried to get people throughout the government, but they sent letters to VA caregivers saying, you are not contributing to American prosperity. You could do more productive work somewhere else, and we would love you to do that. Please leave. I
Right.
mean, imagine running the prospect if you sent me a letter and said, you'd be way better off writing for the New York Times than for
Right.
us.
Right. Exactly.
You know,
And there's another point to this, and it's brought up by a question from Jared. Jared, one of our longtime viewers here at the weekly roundup, and he's talks about the lean for specialists over primary care physicians, and a lot of this is because of the
right,
kind of money you can make as a specialist instead of as a primary care physician. Some of that is because of the pay scales and the reimbursement scales. The American Medical Association basically dictates in some way the reimbursement rates, at least in Medicare. They run this panel, this
right,
board that
right,
recommends those rates,
right.
and a lot of specialists on that board, and they recommend higher reimbursement for specialists than primary care physicians, and therefore you get more specialists. And then medical schools also play a role here, right?
Well, there's a definite prejudice in many medical schools against primary care. I mean, I know many people who
Hmm.
are young medical students who want to go into primary care, and their professors say to them, well, Joe, why would you want to do that? I mean, you're so smart. Why would you want to be a primary care doctor? You could be an interventional cardiologist. And I think that actually, in after my almost well, I grew up with one of these, my daddy was one of these specialists. He was a big time ophthalmologist. So I grew up in academic medicine and remain mired in it. And as far as I'm concerned, you have to be way smarter and more curious and reflective as
Hmm.
a primary care doctor than when you're just doing knees, total knees and show. I mean, you have to be, they're smart, they're good test takers, but
You have to know the whole system. You have to know the whole body. You have to
yeah.
know the current research, and
But
and
I
and
think that there's
it's the
actually,
critical first step of diagnosis. So, if you set someone on the wrong path there, it could be problematic throughout their entire care. Whereas if you're smart and you diagnose this correctly, you can prevent, worse problems down the road.
and also coordinate care, because part of the
Correct.
people get into trouble is the failure of care coordination. And we
That's
see
right.
that all the time. And that's what the VA offers. I mean, you and I have to be our own care
That's
coordinations,
right.
coordinate
That's right.
when, by the way, we're sick, or our family member has to be our care coordinator when your wife or husband has to worry about you
Hmm.
being sick. There was a great scene in Walter Isaacson. I'm not a big fan of his writing, but he to say the least. But but there was a great scene when in his biography of Steve Jobs, when Jobs had pancreatic cancer, and
Right.
I don't know where he was, California Health Foundation. I can't remember what hospital in Palo Alto. And this is Steve Jobs, right? Billionaire, et cetera.
Right.
And his wife had to force the 5 or 6 specialists that were taking care of him and never talked to each other, right,
Right.
to actually meet together. And because
Right.
she was Lorraine Jobs, she could get them to do
Right.
that.
Most of us can't. Yeah, I've seen that firsthand. Okay. Another thing that you focus on in this article is uh, whether or not patients, veterans or non-veterans, will have a hospital to go to near them in the first place.
Yes.
And so you look at rural hospital closures in particular, where we've had this kind of crisis, creating all these medical deserts across the country. So, what is the state of rural hospitals before all of these cuts from
Right.
the
So the state is awful. I mean, we have closures of many hundreds of rural hospitals. They anticipate that about 700 more are going to close. It's not only closures
That's
of,
about a third of all rural hospitals in the
yeah,
US.
right. And and again, this is before the big beautiful bill, right? All of this
Right.
stuff in my report is before. So this is like a healthcare system that's on its last legs, and you are taking away whatever leg they have
Yeah,
to
you're
stand
taking
on.
a hatchet to something that is
Right.
already bloodied.
And so
Yeah,
not only have rural hospitals closed, but the ones that haven't closed, many of them, 20% more or more, have lost services. Something like 25% of hospitals have stopped providing obstetrical services. And,
so if you want to have a kid, you got to travel 4 hours, 5 hours if you're in a
yeah, and
rural
part
area.
of this is part of the crisis in OB obstetrics is obviously the disaster of the refusal to provide abortions, but it's 20 the biggest growing cohort of veterans is women veterans. I mean, they're now like, I think they're 10% of
Hmm.
the population, 14% of
Hmm.
the active duty service member, and it's expected to go up to 20%. So these are women, they have babies, they have wombs, and they need
Right.
obstetrical services. Where are they going to get them, particularly in rural areas? Rural hospitals have also, and this was something that was an eye opener for me, and this was in this report from Chartis. Many of them have stopped offering chemotherapy
Yeah.
services. So you have cancer. I mean, and this is interesting because when Collins was confirmed in his confirmation hearing, he used, I believe, oncology as like, well, they deliver oncology care, cancer care everywhere. Well, actually, Doug, they don't.
Right.
And so and
In fact, like the chemotherapy services that are closing, to a greater degree than the OB services, which are already pretty bad. And
right,
I want to go through. So we say a third of all rural hospitals in the US are at risk of closure. But if you dig in state by state, I'm going to
right.
go through some states right now. Kansas, 66% of their rural hospitals are at risk of closure. Arkansas, 64%. Hawaii, 62%. Vermont, 62%. Alabama, 60%. Oklahoma, 60%. New York, 58%. Texas, big state, 56%. Mississippi, 54%. So that's a states with a large percentage of the population. Those 8 states, or nine, I should say, which have more than half of their rural hospitals at risk.
Oh yeah, and when you talk about this going to hurt us all, so the VA is one of the major. I mean, it shelters Americans from an influx of 9 million veterans
Right.
nationwide, in California 1.5 million, in Texas 1.4 million. So just imagine, what's going to happen when you have your rural hospitals closing, right? So let's just take California because I know it best. So let's just say that all the hospitals in Northern California, or many of the hospitals in rural hospitals in Northern California, close.
Right.
And, you have, so you have UCS, you have Fort Miley in San Francisco, you have Mather in Sacramento, and those close. So
Right.
what's going to happen is you're having all these rural veterans who live, 25% of the California veteran population, right, of 1.5 million. So that's what, I mean, whatever, hundreds of thousands of veterans are going to suddenly now be descending on fewer hospitals that the population, the general population, is going to be descending on. And so veterans are going to compete with non-veterans. And here's what I fear, David. A lot of these veterans have mental health problems, they have addiction problems, they're homeless. So what worries me is that suddenly Americans' love of veterans, which is a very thin veneer, if you look
Right.
historically at how we treat veterans, suddenly, some middle class guys like, why, wait a minute, this veteran, this homeless guy, this guy who's, a
Right.
drunk, who's a drug addict, he wants my slot
He
in
wants
this
my health care. He should be going to the VA. Yeah, it's a
well,
vicious
but there's
cycle.
no VA.
Right,
There's
exactly. Exactly, but that's what the somebody would think. I want to say two more things about rural health hospitals. And the first is that when a rural hospital closes, it's not just about devastating the healthcare system, it's about devastating that entire community.
Oh, yeah.
Often, rural hospitals are the largest employers in that community. And when you get rid of them, the town usually has trouble surviving at all.
Oh,
So that's number one. Number two, there's this problem of where are these people going to go for healthcare? And I talked a couple months ago when the big beautiful bill was being debated. I talked to the former head of the Center for Medicare and Medicaid Services, Chiquita Brooks LaShore, and she told me that she once did a trip in Colorado, rural Colorado, and she had to go from one side of the state to the next, and it was over the Rocky Mountains. And when she got to the other place, she was told by the staff at that hospital that, that road that you just went over, about 1 out of every 3 days during the year, that road is closed.
oh, yeah, right.
And so, it's not just about lack of access, it's about impossibility of access to people who live on the wrong side of that road. And they, instead of having to go to their local hospital, they have to travel over that road to get medical care. So it's just this huge problem. And, in the bill, after a lot of concern from Republicans, they added a $50 billion rural hospital fund that is supposed to cover a $1 trillion deficit in terms of cuts to Medicaid. And it's just not going to be adequate. I think everybody knows that. The same people that push for the rural hospital fund are also pushing to kill the Medicaid cuts, because that $50 billion might help the crisis we're in right now.
Right.
It has nothing to do with the $1 trillion in cuts that we're going to see in the future.
And the other thing I want to point out, and I didn't include it in the report because I just didn't deal with it. I mean, I actually started and decided against it, but if you close VA hospitals, if you close VA community outpatient clinics, which are quite large, there's a huge economic impact, particularly in rural states, but everywhere. I mean, 3,800 people work at the San Francisco VA Medical Center. I mean,
Yeah.
in Georgia, one of the VA hospitals is the largest employer in the county.
Right.
I mean, and you're firing doctors, nurses, and the other thing that's really important to note now is that if this had happened, if shutting VA facilities had happened a year ago, maybe pre-Trump and pre these cuts, doctors and nurses and OTs, social workers, probably would have been able to get jobs in local
Right.
healthcare facilities. They will not be able to now
Right.
because hospitals, even before the implementation of these cuts, I mean, UCSF has a hiring freeze. They've actually fired a lot of people. People are not going to be able to get jobs. And so you're firing, I mean, 25, what is it, 25 to 30% of federal workers are veterans. you're going to fire people. This is going to have a devastating impact.
And it
Not
trickles down, right? I
right,
mean,
and
so
not
you're
to mention that
seeing,
all these veterans will lose their health care
right,
because they. I mean,
right,
it's a shit show. And my hope is that, I mean, one of the things that I'm kind of hopeful about is that there's a fair, there's a pretty big backlash against this. And, I mean, people like
right.
Bozeman and Moran and Blackburn and all, I can name them all. They're all on the VA committees, these people who are pushing for this privatization and who, voted for these
Mhm.
massive research cuts. I mean, not the research cuts, but the healthcare cuts.
Right.
And I mean, it's really,
Well,
it's
and you've written about the backlash and kind of the grassroots movement of veterans, even some veteran service organizations, though obviously not all of them, but that grassroots veterans organizations are getting involved and saying, "Hey, you can't privatize this system and leave us with nowhere to go."
right. And I mean, you've seen the Common Defense, which is a
Hmm.
great veterans group of younger veterans, IAVA, Iraq and Afghanistan Veterans of America,
Yeah.
that I've been critical of before. They've done great testimony. We've seen this surge of this creation of the Federal Unionist Network Fund, which is,
Hmm.
trying to inject militancy into pretty much moribund, federal unions. And then you're just seeing folks, I mean, you go to a VA hospital in St. Louis or San Francisco or anywhere, and you see these people, out front, don't close our VA. And these are not the usual suspects. I mean, in St. Louis, I think we wrote about this in the prospect. A friend of mine went to visit a friend who was a patient in the VA in St. Louis, and he ran into some lady who was giving out, like, Xerox sheets, save our VA. And he's like, "Oh, are you from a union? Are you from some left group?" No, she was a patient's wife. I just a person's wife. And she was
Right.
like, so I think we're going to see more of that. And I mean, one of the reasons why we wrote this article and why I've done this report is to arm activists. So,
Right.
you can go to Bill Cassidy and say to him, well, hello, where exactly in Louisiana are these veterans going to get care, Bill?
Right.
And I think
Right.
that can be pretty, and a lot of Democrats, the other thing is that, I mean, one of the most tragic things to me, and we wrote about this in the prospects all through the Biden years, is, you see Collins doing all these administrative actions to weaken the VA, which is something that Dennis McDonough could have done, the former Secretary of the VA, over his 4 years to strengthen the VA. And, one of the things I think that needs to be written about, and I know we'll do that over the next years, is like, okay, what do we need to do to rebuild
Right.
the VA?
That's what I
Because
was going to ask you. I mean, do you think that now that we're seeing tens of thousands of proposed cuts to VA personnel, that is sort of an artifact of the Doge kind of restructuring and things like that? Do you think Democrats are going to, if they ever get any kind of power back, going to not fall into the same trap of just forwarding along privatization and moving it along? Are they ready to actually protect and defend this system for what it is?
Well, I think that's the one of the silver linings of Trump is that, suddenly these Democrats have become much more militant about the VA. Suddenly the press, I mean, is starting to write about veterans. I mean, from, the Prospect has been writing about this for a decade.
Right.
And it's been extreme. And I have been, and my colleagues at VHPI have been working on this for a decade. And it was like, the VAO, really, who cares? Veterans, who are they?
Right.
And now suddenly everything is all veterans all the time. VA, oh my God, I mean, I talked to a reporter when they started cutting the research, which we wrote about in
Hmm.
another in a paper shall go nameless, and I said to him, "You ought to write about VA research," and he said, "VA what?" And
Right.
so, you know,
Right.
VA teaching, VA what? So this is a huge opportunity, and I don't think the Democrats will do anything without pressure. And
No.
so I think we have to, you know, take this golden opportunity that we have for
Right.
suddenly people are, you know, that whatever the issue is, people are, you know, the weather report, you know, the
Hmm.
all kinds of things that Trump is drawing attention to, and we have to, I think we have to write
Right.
our own agenda and say what we want for the VA. You know,
Right.
you need to expand. I mean, rural health care, the VA is, if you look at rural health care, you know, no private for-profit corporation is going to invest in rural health care because like there just aren't enough patients to make
Right.
it profitable. And
Right.
so, you know, either the government has to do it or the VA has to work, you know, in these areas to do it and to subsidize. It has to be subsidized. It just,
Absolutely. I mean, it's crazy to me. You know, this week we saw yet another one of these stories that you see almost every 2 years, every midterm cycle. Democrats are turning to veterans to try to win back Congress.
right,
There was one this year. I found like 8 New York Times articles going back to 2006 about them bringing on veterans, bringing on veterans, bringing on veterans. But it seems like veterans policies aren't brought on along with the veterans. The veterans are just used as, hey, I'm a veteran, you should vote for me. But, you know, the policy architecture underneath, it takes people like your organization and actual veterans, grassroots veterans who actually deal with this system on a daily basis to say, hey, you know, rather than just use my name and use you know the imprimatur of veterans, why don't you speak to the policies and maybe get veterans to support you?
well, and also, I mean, you know, my interest in the VA is not only providing good health care to veterans, but this is a model for health care we should all have. You and
Absolutely.
I, you know, there are many ways to serve your country, and not all of it is to go, you know, join the military.
Sure.
You know, many of us serve our country, and everybody deserves real health care as opposed to, you know, bogus sort of episodic, you know, broken medical treatment. And one of the things I hope will come out of this, and I hope will come out of it,
Yeah.
is that, you know, the VA should be viewed as a model for, you know, socialized medicine that can help us all. And you don't have to go to, you know, France or
With integrated care, with coordinated care, where people have a medical home. I mean, all of the things that the VA was a leader in digitizing medical records and does it in a way that isn't, you know, doesn't offer opportunities for grifting the way that the current medical coding system does with through Medicare Advantage. The VA has been a leader in, you know, pointing a path forward for a type of healthcare system that we actually could all have. And it
right.
would not only be better outcomes, but it would actually be cheaper for most of our people. So yeah, it's a good way to really spotlight this system. I just thought this was a terrific way to understand where we are now, because we're going to go to a place that may be a little dark in the next few years. And just knowing like we were already in crisis before they made the decision for these kinds of things to happen. And so, you know, the system, because there's going to be this tendency, if Democrats do get back in power, to say, okay, we'll just reverse some of these cuts
Right.
and that'll be it. But if you just bring the system back to where it was at the beginning of 2025, you're going to see a system that you outlined here, where people have trouble getting basic care, and we need to rethink this in a big way. And this article, I think, goes a long way towards doing that. So thank you for doing it.
Yeah, and thank you
And
for supporting my work and
100%. Thank you for being here, Suzanne. Suzanne Gordon is an independent journalist and co-founder of the Veterans Healthcare Policy Institute, where hopefully soon you can find the full 117-page report on the state of American healthcare. That'll be at veteranspolicy.org. In the meantime, you can read many of the highlights in our story that Suzanne wrote and we published at prospect.org. That's all the time we have today. I want to thank you for being here, Suzanne, talking to us about the story. And we are here every Friday at 12:30 Eastern. We also put these videos online at prospect.org, so you can see that in a couple hours. And I hope you come back week after week. Tell your friends, tell them to sign up at our YouTube page, youtube.com. Our channel is The American Prospect, so you can find it there. And have a great rest of your day and a great weekend. Take care.